It is important for revenue management that we capture accurate clinical information. The lack of complete documentation may alter the mortality and morbidity data and the CMI, or Case Mix Index scores. Low CMI and high mortality scores influence the physician and hospital profiles. So let's begin with a few best practices in clinical documentation. Number 1, be more descriptive and specific about why this patient was admitted. Number 2, document your medical decision thinking and restate the most significant items from the labs, the radiology reports, and the pathology reports. Number 3, try to link your actions to your working diagnoses in the progress notes or in the discharge summary. Use words like due to and related to. This will help the coders and clinical documentation specialists put together the set of proper codes to use when billing. Number 4, use words like possible, probable, or suspected, and include words like acute or chronic. Number 5, paint a better picture of the patient's severity of illness, the patient's condition, and the risk of mortality. Number 6, respond to clarification queries in Epic as soon as possible. Let's take some examples. Being specific is important. Instead of mentioning hypotension, which reflects a lower mortality score, if the patient was in shock, say so, and say that the patient was in shock, and this reflects the severity of the case, where in some instances it can be 50 to 70% mortality rate. In regards to pneumonia, note that simple pneumonia has a 2.5% mortality rate, whereas complex pneumonia has a 20% mortality rate. So we need to reflect a more accurate picture of the actual condition that resulted in the patient being treated with multiple antibiotics or being in the hospital for multiple days. The next area is documenting acute respiratory failure instead of just saying respiratory insufficiency. If the patient truly went into respiratory failure or respiratory distress, then say so. And this reflects the fact that acute respiratory failure carries with it a 30% mortality rate. Finally, we were all exposed to the older term of urosepsis, which normally reflects a 1.5% mortality rate, and many of these patients may have had true sepsis, which reflects the 20% mortality rate. So if the patient truly became septic, that needs to be mentioned in the documentation. Here is another slide that shows some examples. When stating anemia, notice that it is a non-specific term, so we need to describe the type of anemia, for example, acute blood loss anemia. Next is the area of weight loss, unspecified, and muscle wasting, where we actually need to mention if it was due to malnutrition, and we need to use the word malnutrition. If there was bacteria in the urine or the urinalysis, we need to mention that the patient had a UTI. And instead of using the term urosepsis, we can use the term sepsis due to UTI. In cases of altered mental status, use the terminology of encephalopathy due to the cause. When talking about COPD, if you notice that the patient was in acute exacerbation of COPD, you need to mention COPD exacerbation. And then, in the area of congestive heart failure, you need to mention whether this was an acute exacerbation and whether the patient has chronic CHF. It is also helpful to mention whether the patient has systolic or diastolic or both dysfunctions.